Thank you, Professor Pandey, to give me the opportunity to be here with an esteemed panel of excellent strabismologists. My topic is acute comitant esotropia. The importance is that we see a lot of esotropia, and it's important to identify those set of patients where whom you have to be more careful in your workup, in your diagnosis, and not just in the complications that arise pre or post your squint surgery. So, uh, acute comitant esotropias are acquired in nature with sudden onset diplopia, minimal refractive error, and usually in the first, second decade, or may even be a little later. So it's important that they are acquired in nature, or at least the patient presents to you at an older age group. They're sudden, and there is diplopia. So in most esotropias which present to us much earlier, usually in infancy or in the first or second year of life, the child doesn't at all complain of diplopia. So you know the patient is complaining of diplopia means he's acquired it recently. The features are that it's late onset, it is sudden, it's in the older age group, there is diplopia. Usually there is good prognosis for binocularity and invariably will require surgery. So we'll just talk about the differentials, but you can see that the abduction is full. There is an esotropia in primary gaze, but the abduction is full. Usually there is no A or V pattern that is associated with it. The classification given by Burian is that the acute comitant esotropia or an esotropia presenting to you in older age group would broadly be divided into two groups. One, where there is a neurological disease which you should look for and essentially should be evaluated for in each and every case that presents to you with acute comitant esotropia. It's like, you know, a neuro-ophthalmological disorder presenting to a strabismologist. So whenever you suspect an acute comitant esotropia or whenever a patient has diplopia, you have to think that could this be precipitated by a neurological disease. Without neurological disease is a vast majority of the acute comitants we see, and there are essentially three types, basically depending upon the pattern of their presentation. Although they tend to share, at least they do have a little commonality to their etiology. So, in the type 1, it is often associated with monocular occlusion, particularly for amblyopia therapy, although it could be for anything. One has seen this being precipitated after cataract. So, overnight occlusion, or just because he was patched after cataract surgery, he broke and therefore presented with to us with squint. So, you can have a squint and esotropia precipitating due to artificial interruption of the fusion after a period of monocular occlusion or visual loss. So, if there was some reason for which vision was lost, like say again in unilateral cataract, the patient may develop an esotropia which does not get corrected after cataract surgery. So, associated vertical deviations may not, but they usually are not there. Sometimes they may resolve spontaneously, although it is very less likely. In the type 2, the Burian-Franceschetti type, it is the commonest. It is the most common type which one would see. It is a large angle ESO with no neurological disease and minimal, at least not very significant refractive error. A common magnitude of myopia or hypermetropia, history of diplopia but inconsistent, and the patient is not so unhappy because he can move about. Sometimes patient, when we have discussed surgery, has said that okay, I'll come back, I'll see, I'll try and see, I'll come back. So they've been the type who have, you know, postponed the surgery for a bit before they are actually convinced that yeah, we should get surgery done, because anyway they've been so scared by frequent visits and by our, you know, worry that there is a neurological cause and we are searching repeatedly. So they're anyway worried about what's happening to them. They have a bit of diplopia, so they may be a little hesitant for surgery in the initial period. Again, the probable cause is an esophoria that gets decompensated. So this can be associated when the patient may not give you a very discrete history of a period when there is a chance of a loss of a binocular control, like a period of when the patient was significantly ill or some other reasons, not wearing his refractive correction for a period of time. So a decompensated esophoria is the possible cause. In the Bilchowski type, it's usually associated with myopia, with very large magnitude of myopia. The esotropia is more for distance than for near. There is good fairly good. If you are able to correct it, they're fairly good binocular functions, and it increases with time. One of the possibilities is not very clear, the literature is not very clear on this type, but one of the possibilities is that it was reported, and they may have been patients, because very high myopia has been reported in these patients. It could be a kind of strabismus fixus, or kind of a very, because of the large globe, that possibly this may have been precipitated, although again in this type it's not very clear exactly what the presentation would be, but in these cases you see a very high myopia. And in type 3, like I said, essentially it's muscle tone, increased muscle MR tone, or damage to the LR, or compression of the LR from the orbital walls, and the results are very satisfactory again. So the mechanism proposed by von Nuden for the type 2 is the loss of borderline fusion and poor fusional divergence, and the precipitation of the non-accommodative comitant esotropia. The important thing here is the differential diagnosis. To come to an esotropia and a patient walking to you with diplopia, you hardly have any problem. The problems are that you need to differentiate it from a sixth nerve palsy, you need to differentiate from divergence paralysis. Again, most of them, you need to think of a neurological cause. It's again important for you to identify, we've talked about Duane's retraction syndrome, and of course the most important thing you must look, just because the child is in his teens, don't think in terms of that there is no likelihood or no chance of an accommodative esotropia. You must refract, do an age-appropriate cycloplegic refraction in these patients to identify the refractive error, give the appropriate correction, and then after a bit of time see what is the magnitude of deviation. And also sometimes they just noticed it because of an incidental trauma. It's a missed infantile ESO, so you can just ask for old photographs and you can recognize that there was a small amount of ESO that was present earlier, and now either there has been a medial rectus contracture over a bit of time, but of course you'll have abduction deficit in this, but it's rare to see, but sometimes one has seen that parents complain to you late when the child is much older. When to suspect a neurological disease? When it's not fitting into any of the described types, there is no apparent cause, there may be nystagmus, there is problems, associated neurological problems, must think. But essentially I would say in all patients of acute comitant esotropia, you must neuroimage unless you have very clear evidence otherwise. So I would say that neuroimaging is almost mandatory in all these cases. And of course you have a lot of neurological lesions that can be associated, particularly around the pontine region, cerebellar tumors, and Arnold-Chiari malformation is something which we have seen in a couple of cases. The treatment can be initially with prisms, but usually surgery is required. It's important that if it comes in children who are in the amblyopia age group, you must give amblyopia therapy to prevent development of amblyopia. The alternative for management is prisms, although that's not something which is